Good afternoon, everybody. You're most welcome to the Scale Neonatology Virtual Clinical Grand Round. I hope we're going to have another successful afternoon with a great group of people. We've got like 100 people registered or over. People are still joining, but they will find us on the way coming. My name is Dr. Kathy, a neonatologist in Mbali Regional Referral Hospital in Eastern Uganda, and I will be chairing the meeting this afternoon. So we'll be talking about necrotizing enterocolitis, which we all know as NEC, so we can perhaps shorten the time by using the abbreviation. We'll be talking about the diagnosis, advances in care, and the management. And we've got presenters both from the UK side and from the Uganda side. Just before I introduce them, if you have questions, kindly type them in the chat, or if you prefer, you can raise your hand, but possibly easier if you can pop them in the chat. And we'll come to the questions at the end of the Ugandan presentation. Then we'll have a few questions at the end of the UK presentation, and then we'll have time for a discussion at the end. I would like to welcome our colleagues, Dr. Juliet Adongo and Dr. Nelson Okello. Dr. Okello is a lecturer in the Department of Pediatrics and Child Health at Lira Regional Referral Hospital. And Dr. Juliet, she's a pediatrician at Lira Regional Referral Hospital. You're both most welcome. And please go ahead and share your screen, Juliet. And we look forward to hearing what you have to share with us this afternoon. Thank you.
I'm called Dr. Juliet Adongo, a pediatrician based at Lira Regional Referral Hospital in Uganda. I'm going to present to you a case of neonatal enterocolitis, which we manage at our hospital. Thank you. Yes, so briefly about Lira Regional Referral Hospital. It is a regional referral hospital serving the 9 districts of Laon sub-region with a population of 2.5 million people. It receives referrals from about 94 lower health facilities and which refer to the hospital. The neonatal intensive care unit of Lira Regional Referral Hospital has a bed capacity of 10 cots, but we can squeeze in like about 20 because of our admitting capacity. We have 1 kangaroo mother care room with 4 beds. We are equipped with 2 incubators, 3 radiant warmers. We do not have CPAP, but we improvise. And then we have staffs of 5 nursing and 2 pediatricians in the unit. Our admissions range from 60 to 80, and these are babies with weights of 800 grams and above. The objective of this presentation is to present to you a case of necrotizing enterocolitis in a preterm infant in Uganda, and also to give an overview of management of preterm infant presenting with NEC in resource-limited setting. And then my colleague, Dr. Nelson, will discuss the challenges faced in managing these preterm infants with NEC in a resource-limited setting. So the baby I'm presenting, the mother is AS, a 19-year-old, para 1+0, a peasant farmer, seropositive on ART. The pregnancy was not planned for. She attended antenatal care twice, got 2 doses of tetanus toxoid, was given oral imatinics and malaria prophylaxis with Fanxida, and was also dewormed during those two visits. At about 28 weeks of pregnancy, she developed a febrile illness, which was treated as malaria in a clinic. But few days later, she started draining liquor, was admitted in the hospital, was managed for PROM with antibiotics and also got corticosteroid. But 2 days after admission, she developed labor pains, and then thereafter she delivered a live baby boy, which weighed 800 grams. The baby scored 8 and 1 minutes and 6 at 5 minutes. 6 at 5 minutes. The baby was resuscitated with ventilation only, given vitamin K, tetracycline, and then transferred to the neonatal intensive care unit in the hospital. 6 hours later, the baby was received in the NICU with complaints of prematurity and difficulty in breathing since birth. At the time of admission, the temperature was 35.8, was saturating at 72 on room air, and had a pulse rate of 160 beats per minute. A Ballard score was done, and the Ballard score at 28 weeks, the baby had a length of 37, and the head circumference was 28 centimeters. The child was active, though had peripheral cyanosis. There were no obvious dysmorphic features noted. On systemic examination, significant finding was on the respiratory exams, where the child was in severe respiratory distress with a SAS score of 7. However, the chest was clear. That is briefly our SAS score, if you can see. It helps us determine the severity of respiratory distress which the child has, and it helps us guide decision to start CPAP. So the impression of extremely low birth weight at 28th week, preterm infant, sero-exposed, who was high risk with respiratory distress syndrome and potential sepsis was made. So we were unable to do baseline investigation, but the child was immediately initiated on CPAP. And after CPAP, few hours later, the oxygen saturation improved actually to 96. The child was started on IV dextrose 5%, 10 mils, given every 3 hours, but the following day, it was changed to 10%. The child was also given IV ampicillin, gentamicin, and then aminophylline, and was also put on syrup nevirapine for prophylaxis. On day 2, the child was fairly stable on CPAP. So the child was initiated on expressed breast milk, and the child was started on 2 mils of EBM via nasogastric tube. This was progressively increased by 2 mils every day, and the child was fairly stable. On day 10, when the child was taking 8 mils of expressed breast milk via nasogastric tube, the mother reported the child was not tolerating feeds. And she reported the child was vomiting, she had noted abdominal distension, and the child had not passed stool for about 2 days. On examination, the child was found not active, was hypothermic with a temperature of 34.5, and had greenish aspirates via the nasogastric tube. So significant finding on the system at that time was on abdominal, where the abdomen was tense and had distended, was tense, distended with visible veins. Few boil sounds were had on auscultations, and when a rectal exam was done, we got blood-stained stool. So immediately an impression of necrotizing enterocolitis was made. And the investigations done, we did a full blood count, which came out normal with a white cell count of 22. The hemoglobin level was 13.7 grams per deciliter. Platelets was 260. Abdominal X-ray, were unable to do it because we had no portable X-ray, and the child was very, very sick on CPAP. So we were unable to transport the child to the X-ray unit. So we didn't do that. Random blood sugar was 6.5. We also removed samples for electrolytes, but we were unable to get the results back. Possibly there was a problem with the machine. We also wanted to do a CRP, but this is not possible because we don't have CRP. We don't do CRP at our facility. Yeah, so immediately on the management, the child was put under radiant warmer to warm up. We continued with CPAP and aminophylline. Nasogastric tube feeds were stopped. All feeds were stopped, including the meds. We put the child on nil per os, and the nasogastric tube was left on free drainage. We reinstated antibiotics. Since this was day 10, we had stopped at day 5, the initial ones. This time we changed to second line. We started cefotaxime and amikacin, and also added metronidazole since the child had features of neck. We also gave IV fluids, dextrose 10% and normal saline every 3 hours. Baby was also given vitamin K, 0.5 milligrams for 3 days. 2 days later, the child improved, showed some improvement, was stable on CPAPs. The vitals had stabilized, had normalized, though the child still had mild abdominal distension, and the aspirates via NG tube was now clearing. The contents were yellowish in color. On day 14, we continued to monitor the aspirates, and by day 14, the aspirates had cleared. So we reinstated the child on express breast milk. on 1 meal. This was 12 meals per kilo per day. So the child was taking 1 meal, and we did cautious feeding. We were observing, and the child was tolerating. So we gradually increased this every day by 1 meal. By the time we reached day 20, the child actually was stable, was able to tolerate feeds, and was passing normal stools. So we weaned the child off CPAP to nasal prong oxygen, and then eventually to room air. We initiated the child on kangaroo mother care and was transferred to kangaroo room. At the time of transfer to the kangaroo mother care room, the child had lost weight and was weighing 686 grams. So that is the picture of the baby just before transfer to kangaroo mother care, and the child eventually was taken to kangaroo. Thank you for listening.
Thank you, Juliet. Are you going to hand over to Nelson now?
Yes, Dr. Nelson is going to proceed with the discussion of the case. Thank you. Dr. Nelson, you can take over.
Yes, thank you very much, Juliet, and thank you, team. My name is Dr. Nelson Okello. I'm a lecturer in Lira University, but we offer, support to Lira Regional Referral Hospital as one of our training sites. So I will be taking a few points here across for a discussion today. Some of the issues here probably will need expert opinion, and as I've highlighted, we'll be able to call for a discussion. So we noted a key discussion point in the case presented by Dr. Juliet. And one of the most important questions that this case raises is the issue of comorbidity. So you realize, this baby was actually exposed and would, regard as a low-risk baby since the mother was on heart, actually during through the pregnancy. And so the question of whether to halt feeding in the presence of necrotizing enterocolitis, and also, stopping nevirapine syrup, which is required for prophylaxis. That's a very big issue that we probably need to talk about. What do we do in that case? The baby is exposed, but the baby has developed necrotizing enterocolitis, and one of the guidelines says nil per horse. We do not make anything past of this baby's mouth. But also the other thing is about feeding. Considering in our setting, we do not have total parenteral nutrition, and this is really associated with the growth failure. And so I think we will need an expert opinion on this. In this case, what would we probably do differently? The other issue is when to restart enteral feeds after diagnosis of NEC. I think the case that Juliet has presented, this baby was first responsive to this care, and therefore within a period of about 5 days, they were able to reinstate enteral feeding. And but I think it's a great clinical dilemma. So when exactly do we start, feeding after diagnosis of NEC? Now, the learning point that we pick from this case is that management of necrotizing enterocolitis really requires a dedicated team. And I would like to applaud the team in the Lira Regional Referral Hospital. You realize this baby was really too small. And one thing that we observe is that, there was really a dedicated, management staff on the ward, the nursing team and the clinic, that the prescribers were actually available most of the time to look after this baby. And therefore they were able to identify, new complications that would come, like hypothermia, like hypoglycemia. So we learned that really management of necrotizing enterocolitis in the preterm baby is quite a challenge, but requires, presence of a dedicated team. And reviewing this case, I really noted that, as I would actually say the region, the Lao sub-region really has a lot of limitations when it comes to management of small and, sick newborn. In terms of investigations and, other things. But we could see that this baby was able to be saved despite all these challenges. And I think what we observe is that there was a lot of effort put on monitoring of this baby and the nursing care and all that. But we noted another challenge in this case. You realize this baby needed to be on NG2 for decompression purposes. And what we see from here is that we meet a lot of challenges from caretakers, specifically mothers and grandparents that usually surround our patients, our small patients. And so they have a lot to do in the decision making. So whether to put a tube, or sometimes they reject. There's a perception that putting a tube really would appear like a death sentence. So we face that challenge, and we really want to get away. How do we overcome this? How do we communicate to parents in this case? Another thing is that we noted a very big gap in the investigation in this case. We realized the clinical team were quite aware of, what kind of investigations to do. But because of logistic challenges, and lack of these equipments and others, most of the things were not done. There are some baseline investigations that could have been done in this baby, including abdominal ultrasound scan, coagulation profiles, some inflammatory, markers like C-reactive protein. Now, these could only be requested, but would not be able to get the results. So through maybe just a clinical assessment and all of this, it was by God's grace this child was able to survive. Next slide. Dr. Juliet, please move it to the next slide. Great. Okay. So the other thing now is on the current guideline on the management. So as I think Uganda currently still do not have a specific guideline on the management of necrotizing enterocolitis, and really generally guideline on newborn care. But we have a pocket guide that has been released for health center force and hospitals in 2020. And it's really a general guideline for the management of sick newborn. So in this case, the common practice that once you suspect or diagnose necrotizing enterocolitis, then you need to hold entero feedings. Stop anything per mouth, and pass nasogastric tube. And the purpose here is no longer now for feeding, but you are going to allow for decompression. And in this case, able to do low intermittent suctioning of the gastric content, because realize that in necrotizing enterocolitis, the gastric emptying is actually quite delayed. So you do not want to allow for bacterial growth, so you have to decompress. Then antibiotics, usually our first line antibiotics for all sick newborns is ampicillin and gentamicin. And that's what we have in practice. And if you have a late onset necrotizing enterocolitis or late onset neonatal sepsis per se, then we would expect to substitute ampicillin with cloxacillin, and gentamicin is usually substituted with amikacin. And in this case, when you diagnose or actually suspect, like in our case where we do not have, services for investigation, most times we suspect, then you are supposed to add metronidazole, just like it was seen in the case above. So the other thing which is quite important, the management of necrotizing enterocolitis is intravenous fluids. But here you need to really be very observant and keen in the volume and the type of fluids you are going to give. As you realize in the first 72 hours, we are not so much concerned about electrolyte derangement. So we tend to give fluids without electrolytes, like D10%, D5 preparation. And unfortunately, we also don't have a ready-made fluid of the nature. So sometimes we reconstitute manually. And in that case, then we need to continue monitoring fluid and electrolyte status, especially after the first 72 hours of birth. Like I said, we do not have access to total parenteral nutrition, but this would be a good substitute in the face of necrotizing enterocolitis. Next. Yeah, so here are a few highlights of experience and ideas about implementing some of these. So you realize that in this case, there were a number of suggested radiological and laboratories services, and all these services, almost all actually not accessible in our setting. And X-ray is there, but most times we find a lot of breakdown, power issues, and so and yet in the private laboratories, they are really quite expensive for a common person. The other issue is the turnaround time for available tests. It's usually very long, and you could see from the case that Dr. Juliet presented. You order for a test, you probably wait for the whole day, and surprisingly, you follow up our results, you don't actually find the results anywhere. So sometimes they get lost. Now our turnaround time is really quite long. So sometimes we needed to private practitioners, private labs, and all these are very expensive. The other issue in our settings, we have a very big concern with antimicrobial resistance. And there's evidence that actually there's so much resistance to ampicillin. And sometimes, you have to keep these babies quite long in the hospital against the risk of also hospital-acquired infections and all that. While the recommended alternative where there's resistance are really not an essential drug list if you are talking about medicines like vancomycin and all this. So they are really quite expensive. You should turn to an alternative source. The other thing that we observe from the presentation is while a lot of effort was put on the monitoring of this child, but you could see from the case and the background of the facility that there's quite inadequate staffing, where we are looking at a nurse-patient ratio of 1:30. But you realize these are really very, very sick children that require a lot of monitoring, and most times actually a 24-hour attendance to the patient. There are a lot of needs that need to be fulfilled by a attending nurse. But in the face of inadequacy of staff, then this becomes a very big challenge. Next. Yeah, so those are a few issues that I thought we could raise given the case presented, and I would like to end here and probably welcome any question or concern. Thank you.
Amazing. Thank you, Dr. Nelson. Thank you, Dr. Juliet. Fantastic presentation and some really good thoughts for discussion now from everybody else. I can see a few hands up and a question in the box. Everybody else who's online, if you do have a question, please just raise your hand or type something in the box. We've also been joined by Dr. Kath Harrison, who's a neonatal consultant from Scale Neonatology program in the UK. So she's also around to help give us expert opinion from the UK, as well as we have Sam's presentation coming up. I just kind of had one comment for everybody really, and Juliet and Nelson together, but here, our setting in Uganda, it's really challenging to treat NEC, and I think you've highlighted that fantastically in your presentation. The lack of everything, nurses, drugs, fluids, TPN, it's really hard. And I think for us here in Mbali, we have the same challenge. And indeed, we have one nurse to about 110 babies. So I feel your pain. I think the key for all of us has to be about prevention. And I noted in your presentation that the admission temperature for baby was 35.8. And hypothermia is like the biggest risk factor we have for mortality. It's a risk factor for IVH, risk factor for chronic lung disease, a risk factor for NEC. And I was just wondering whether we might explore, perhaps with you guys and anyone else on the call, and I apologize if I missed it as well. I didn't see the antenatal corticosteroids, but at least here in Mbali, we're terrible at giving those antenatal corticosteroids, primarily because the mothers prevent almost about to deliver, so we don't have time. But I think as a group of individuals on this side, on the Ugandan side, we could really think about prevention here, making sure our mothers are perhaps more aware, getting those antenatal corticosteroids in to prevent NEC, but also our thermoregulation and our management around the time of delivery. And our next grand round will be about kangaroo, but immediate skin to skin has of late been proven to be effective and reduce mortality in all settings, high and low income. So I'm interested, Juliet or Nelson, did you practice immediate skin to skin? Do you transfer the babies in a baby warmer like an embrace or a Womelu, or do you transfer the baby on skin to skin? Just as a thought of how we may have prevented this, I think you did a great job of the feeding. I really love that you're using breast milk and not formula milk. So I was just trying to think of ways that we could stop neck coming, because as you've highlighted, it's a huge challenge for all of us. So Juliet, maybe you want to just comment, and if anybody else has any thoughts on how we can prevent neck in a low resource setting, that would be great to hear. Go ahead, Juliet.
Okay, thank you so much, Kathy. Yes, for our referral mechanism, because we have a maternity unit and a neonatal unit is in another building. So this baby actually required resuscitation and was very sick at the time of delivery. I was ventilated. So normally it is the attending midwife who refers the baby. And we do not do skin to skin because the mother may be in maternity. That's why I think the child was even admitted hypothermic, and the child also took some time in maternity, came 6 hours later. So the same challenge of staffing is the same also in the maternity unit. So you'd find the mother still stabilizing the midwife, first stabilizes the mother, then eventually has to come and transfer the baby. But for other referrals that we receive from the lower health facilities, during the transport, as they are transporting them, we put the baby on skin to skin if the mother is available. But if the mother is not there, then we just wrap them up and then bring the baby. We don't have any transport incubators or anything to transfer these babies. So when we can, we use skin to skin, but if it's not available, we wrap up the child and then immediately transfer. Noted also, we don't have a portable oxygen. So most times we carry these babies first without oxygen and then transfer them. That's why we receive babies with very low oxygen saturation, which is actually a very high risk factor for NEC in these preterms. Thank you. Over to you.
Thanks, Juliet. Actually, it was about a year ago now. We transformed, Juliet, one of our transport trolleys into a transport. It's not an incubator. It's just a baby trolley, but we welded on some bits of metal and we have some cylinders for oxygen. So we have the same challenge as you with temperature, but at least with that homemade transport trolley, we can prevent the hypoxia on admission. Kath, you have your hand up. Go ahead.
Yeah, thanks very much. So Juliet and Nelson, that was a fantastic presentation, and I think it just makes us realise how lucky we are in the UK to have the things that we do have to treat our babies. I mean, the way you describe the antibiotic resistance, the no access to TPN, and your nursing ratios make us feel very privileged in the UK. But I think what was quite impressive to me is actually the questions that you raised, Nelson, right at the end about when to restart feeding, etc. Despite all of the interventions, all of the investigations that we have in the UK, we have exactly the same challenges as you. We always have a debate with our team about the length of antibiotics. Sometimes it's 5 days, sometimes it's 7 days, and then the time before you start feeds. And I noticed you restarted feeds at day 5. We sometimes refeed at day 7 or day 10, but again, that is a variable target, and I don't think actually anybody really knows the answer about that. So it's interesting that despite the sort of different resources available, we all have the same dilemmas really. But I think you did an amazing job with that baby. So congratulations to Juliet and your team for managing the baby so well.
Thanks very much, Kath. I mean, I think as well, we have the added complication on our side, Kath, where if you go beyond 5 days without TPN, you've got that bigger risk factor of electrolyte imbalances and growth failure. So yeah, and maybe just to add on for those on the call, and Nelson, you highlighted the lack of national guidelines for neonatology. They're almost done. We've been working really closely with the Ministry of Health, about 200 pages, so you won't be short of reading. There's a section in there on NEC, and once they're finalized, I will share around specifically with this group the Ugandan guidelines for managing necrotizing enterocolitis, but you will all be able to access those guidelines within the next couple of months. We have a couple of questions in the chat. So one question, Ibrahim, maybe you'll just clarify how to start feeding. Is that how to start feeding when the baby's born, or how to, like Dr. Kath has just been mentioning, how to start feeding after NEC? You can say, or you can type, or maybe, are you there, Ibrahim?
Yes, Dr. Kathy, thank you so much. I'm calling Dr. Ibrahim. Am I audible?
Yes.
Yes, thank you so much. I'm Juliet's president at the Referral Hospital. My question was, there was a question before mine. They were saying when to start the oral feed is after you stabilize the child, was resolved, but then when to start. Then the question is how to start. Like, are you going to start with like the same fluid, like 1 ml per kg immediately, or you start lower, like 0.5 ml per kg, then you increase the scaling up after every day? My question. Thank you.
Thanks, Ibrahim. I mean, again, it would be interesting to hear from Kath and maybe from Sam later. It's still quite controversial about how rapidly we increase feeds. Traditionally, we believed that, I say traditionally, in the old days, we believed that we go slowly and steadily to increase milk. The thought being that rapid increases in milk from the day of birth would increase the risk of necrotizing enterocolitis. And alongside that, Ibrahim, we know that formula milk for sure increases the risk of necrotizing enterocolitis. In Uganda, obviously, we have limited access to formula milk, and we don't really have the challenges with mothers not wanting to use breast milk. So the main limitation we have, at least in Mbali, is the volume of breast milk coming from the mothers, because they tend to be sick or malnourished or whatever. But we do primarily use breast milk here. There's a changing evidence now, and it is changing. It hasn't completely changed, but even data coming out of Kenya shows us, Ibrahim, that actually, even if we more rapidly advance the feeds by like 30 or 35 mils per kilo per day, rather than the traditional 20-25 mils per kilo per day, it doesn't actually increase the risk of necrotizing enterocolitis. So I'm interested to hear from Dr. Kath as well, but I think it's a changing landscape, Ibrahim, and I think actually the sooner you can advance feeds with breast milk in the first few days of life, the better, particularly in our setting where we don't have access to total parenteral nutrition. And we have a huge rate of growth failure here in Uganda. But Kath, I don't know if you've got anything to add.
Yeah, I can add, and I don't know whether Sam's going to cover it. I'll ask Sam first if he's covering it in his presentation about speed of increase. Sam, are you?
Yeah, I was going to touch on it. I was going to talk about the SIF study and.
Oh, perfect. Okay, so I'll let Sam do. But I was just going to echo what Kathy said. There's the study that Sam will cover in the UK says very similar to the Kenyan study, but I'll leave that to Sam to go over.
Great, thank you.
And I was just going to say, in terms of after NEC feeding speed, we start at 20 mils per kilo per day, and then the next day go up by another 20 mils per kilo per day. So we go up very slowly in terms of feed tolerance, because we know that babies with NEC sometimes when we restart feeds can end up, if they had quite severe neck, can end up with a stricture. So we go very slowly when we do reintroduce feeds, and it's always breast milk or donor breast milk, because we know that that is much better for the gut and tolerated much better.
Great, thanks, Kath. There was a question about microbiology in the chat, but I think Dr. Nelson has answered that. And I think many of us have that challenge of not having access to blood culture or to quality blood cultures. But I think as well to acknowledge that blood cultures are not the best investigation in our small friends. They have a really low sensitivity. So I don't think any of us should feel bad if we can't do our blood cultures. And I think for me, at least the key focus for us on the Ugandan side here is to focus on the clinical diagnosis. If you think you've got neck, don't delay, don't think I'll wait till tomorrow, because we don't have access to surgical interventions. If we perforate, for example, then the game will be over. So I would be a little bit more conservative in our setting. And if tomorrow the baby's absolutely fine, maybe we got it wrong. Okay, but yeah, let's be careful there. There's another question. Just wondering why you gave D5 as the initial fluid. So typically, we would use D5, at least in Uganda, for babies under 1 kilogram or under 28 weeks because of the risk of hyperglycemia in the small babies. Kathy, you've said you would start at D10 because the energy needs are higher. That's an interesting difference. Maybe we could just discuss that for a minute before we move on to the next presentation.
Yeah, I mean, I guess we start most of our babies on D10 straight from birth, because we know that they have quite high metabolic needs. And then obviously we are in a very privileged position that if they do have NEC, then we have obviously TPN, and we we would adjust our carbohydrate concentration depending on what their blood glucose is running at. We do know that quite a lot of the preterm babies less than 28 weeks do end up with hyperglycemia, exactly as you said, Kathy. And so we sometimes end up, there's a debate about whether you pull their dextrose concentration back to D5 without insulin, or do you run them at a high dextrose concentration with the side on with insulin. But again, we're in a very different position to you. So we are seeing more and more small babies, growth restricted babies who have hyperglycemia. So I would think in a setting without insulin, then D5 is probably the way to go.
Great. So it sounds like we're saying the same thing. We have no access to insulin infusions here in Uganda, at least in the public hospitals. So I think D5 for anyone on the call for babies under a kilo or under 28 weeks for the first 48 hours is probably the way to go. One last question. I can see Juliet's hands up, so I'll take the last question in the chat, then I'll come to you, Juliet, and then we can move on to Dr. Sam. So the question, when do you consider involving pediatric surgery? I would say there's very few centers in Uganda that can operate on babies this small, and typically neck, we're talking about babies under a kilo, maybe under 1.2 kilos, not always, but we are, and it's a huge challenge both in surgical expertise, but also an anesthetic expertise. And even for us who are lucky enough to have those here in Mbali, we don't have a neonatal intensive care unit to ventilate those babies post-operative. They'd come back to the neonatal unit, onto CPAP, onto oxygen with one nurse to 100 babies, which we just can't monitor. So I think the answer, at least for, and I know Sam will go in on the UK side, but at least Ibrahim for the Uganda side, if your neck has got to the point where you need a surgeon, you're too late. So let's treat conservatively, and let's just have a high awareness for babies who may have necrotizing enterocolitis. Juliet, go ahead, and then we'll move on over to the UK.
Okay, thank you. I wanted to comment about the fluid, the D5 and the D10. Okay, in our setting for babies less than 1 kilo, we start with D5. Our main worry is they have fragile veins, so we are scared about phlebitis, the high concentration. So we start with D5 on day 1, but by day 2, we change it to D10. And this has actually worked for us in most of these babies. Thank you. Yeah.
Thanks, Juliet. And I think all of us have a challenge with monitoring blood sugars. In an ideal world, we'd have a glucometer that matched the glucose strips and we could adjust between D5 and D10. But I think, yeah, we're all a little bit blind, but D5 is okay, D10 is okay. And if you have the ability to monitor your blood sugar of these small babies, then that will definitely allow you to make a more informed decision. Fantastic. What a great presentation from Lira, and some great questions and not so many answers, but hopefully we will get some more answers over the coming years, and we'll definitely get those guidelines out. Introduce Dr. Sam Wallis as a neonatal consultant who's practicing at Bradford Teaching Hospital. Sam, you're most welcome. We look forward to your presentation. So please go ahead and share your screen.
Hello, thank you. Thanks, Kathy. So I'm with Catherine Sutcliffe, who's one of our senior nurse educators, and we've got Dr. Locke, who's also one of our consultants in the room, and Dr. Thomas just popped out, but thanks for having us. I'm one of the consultant neonatologists in Bradford, and Catherine's one of the senior educators who works with us. We're just going to do a little bit about the background of necrotizing enterocolitis, and a little bit about how we try to prevent it and manage it. But as Kath said in the conversation after the first presentation, we haven't got all the answers, and it's a very challenging condition both to diagnose and manage. So just a quick bit about us. We run a neonatal intensive care unit in Bradford. Bradford's a big old industrial mill town or city in the north of England. Quite a young population for Britain, quite a deprived population. A lot of relative poverty in the city, a lot of disadvantaged families. We've got a 31 cot unit, 14 intensive care and high dependency beds, and we look after gestations anywhere between 22 weeks onwards. We don't have acute paediatric surgery on site, so that's based in Leeds. We do have a surgeon who comes to visit us and support us, but we don't have the access to acute surgery. So we do try to medically manage neck where we can, but sometimes babies need to be transferred out. So necrotizing enterocolitis, we've talked a bit about it already, is essentially inflammatory bowel disease, usually seen in premature babies, although very occasionally can be seen in older babies, particularly cardiac babies or babies that have a very severe hypoxic insult. The vast majority of the cases we see are in premature babies, and the more premature you are, the more at risk you are of developing it. I think it's a complex causal factors, but essentially starts with a degree of local inflammation in the bowel that then progresses to a necrotic area. And that releases a lot of inflammatory, causes a quite significant inflammatory response. And the more extensive it gets, the more it can lead to a systemic and multi-organ involvement, and babies can become extremely sick indeed. And it can be fatal, and in the worst cases can be rapidly so. So in terms of causes, it's a multifactorial thing. So you've got an immature bowel that isn't perhaps, the cells within it aren't as tightly stuck together as they were in a term baby. You've got ulcerations in the blood perfusion in the bowel. So you might have areas of relative hypoxia, particularly as babies get more premature. The gut's not really designed to be working yet, so you get a degree of stasis in the bowel, and the bowel's not peristalsing and moving things through, so things can sit and stagnate. So you've got a bowel that's not really ready for the job it's designed to do, and the more premature that is, the more that's an issue. And then you've got the microbiome, the things living within your bowel, and that can be affected by many different ways. We know that bowels don't stay sterile for very long. They quickly get colonized with bacteria, and we can have some effects on that in terms of the antibiotics that we give. That will strip a load of bacteria out, but it may select for bugs that are resistant to those antibiotics we treated. And if we're using things like antacids, we're dampening that down in the stomach and then letting bugs potentially get through into the bowel that might cause problems. Milk's a big part of it. We've talked about this already, but we particularly want to avoid human protein in premature babies, because the baby's immune system is more prone to react to that and for problems to occur. So we know that NEC is more common when we've been using formula milk rather than human milk. We do sometimes use donor milk, but we prefer mum's express breast milk, and the more premature you are, the more we're keen on that. And then there's all the other things that are going on. This doesn't happen in isolation. A baby's born premature, and they have multiple comorbidities, so they may have significant breathing issues, that may worsen the hypoxia, and they may be systemically unwell, and that's always a factor in it. And then genetics is a bit of a crude way of describing it, but these things are very multifactorial, and we're not quite sure why certain babies get this problem and certain babies don't. Even with all the risk factors, it's not always entirely predictable. So the challenge is, well, the unpredictability is one of them. We've had babies, 22, 23 weeks with lots of risk factors for NEC, and they don't get it. And then we've had some that are older and seem to be relatively low risk, and they do get it. So we're not sure why babies get NEC. It also happens sometimes, even though we take all the precautions we can, babies are still unfortunately develop this condition, and sometimes very severely. And it can happen at really unfortunate time, in that their initial care is their stabilization. They're all well for the first few days, first week or so, and then they appear to get a bit better. Parents get their hopes up, particularly for the very premature babies, and then this can come out of the blue really, and be really very tragic for the families and the babies when this is a severe case. Its severity, as we talked about, it's very variable. We see quite a lot of what may be mild forms of NEC, a degree of inflammation that settles with conservative management, but it can be very rapid and very destructive indeed. Diagnosis, there's no easy way to diagnose it. All the tests that we use are really just trying to put the picture together, give us a bit more information, but there's not a sort of definitive test, other than perhaps a laparotomy, opening the baby up to have a look, that will tell us for definite whether the baby has NEC. So we're always slightly working in the dark. And there's always lots of other causes. Babies can get a big belly for lots of reasons. CPAP can give you a big belly. The gut just not moving things through as quickly can do that. The more skinnier baby is, often the belly looks a bit bigger. People naturally worry about these things. It's very difficult to be specific about when that diagnosis is real. And that means that management can be challenges as well when you're slightly operating without a definitive diagnosis. And particularly, as you've talked about already, with any management that we do has consequences. So stopping feeds, antibiotics, that's depriving the baby of nutrition. Putting lines in can introduce the risk of infection. and all the things we have to think very carefully before we start things, and it can be a real challenge. So a quick case study just to run through a couple of things, and this is sort of perhaps a more severe end, but it's certainly cases like this we've seen in the past. So this was a 27-week infant, and mum had received antenatal steroids, which is good, but baby was born by a cesarean section for absent or reverse Dopplers. So the perfusion to the from the placenta to the baby was felt to be compromised. They were worried about the condition of the baby, so they thought it was, although we don't like to deliver babies prematurely, the worry was that this baby was no longer getting the necessary perfusion from the placenta. So they were delivered, they were born growth restricted, so the second centile weighing 630 grams. They were quite sick to start with. They were hypertensive. They developed an early onset infection, which wasn't expected, so they needed quite a lot of treatment. They had a large patent ductus arteriosus as well, which has been blamed in some cases of causing additional gut perfusion problems. So they had quite a few risk factors there as well. And they had then ongoing problems with getting them to grow. So we were using maternal milk. We had fortifier to that at times. But baby was really struggling to both manage breathing without support, so they were on some CPAP, but they were struggling to take the necessary volumes to grow. So they ended up having jejunal feeds, which is something we slightly reluctantly sometimes do, where we're passing the tube beyond the pylorus and into the jejunum or duodenum and giving them milk that way. But baby, that was the only way we found that we could get baby to grow. Baby did improve, seems to be doing okay, but then at 4 weeks of age, and the more premature the baby is, sometimes the longer the delay between birth and the onset of NEC, and baby suddenly deteriorated on a weekend day, developed vomiting, had apneic episodes, went bradycardic, and really very rapidly progressed over the next 2 to 3 hours. This is the X-ray of babies. I know you've not had huge access to X-rays, but it just sort of illustrates the extent of how nasty this condition can be. So we can see there are lots of dilated loops of bowel. There's no gas down into the rectum, which can be a sign of things aren't moving through. There's gas in the portal system in the liver there. You can see gas over the liver, which is a sure sign that gas is leaking out. The gas in the gut is leaking through the inflamed and necrotic bowel walls into the liver system. So gas there is a really significant sign. And although the bowel wall doesn't look particularly thick in there, I think there's areas of pneumatosis, so that's gas in the wall itself. That's all illustrating what an extensive inflammatory necrotic response this baby's suffering. And it's not surprising, I think, that all those gram-negative bugs that should be sat in the gut are now being released into the baby's bloodstream and causing a very significant illness. As you can also see, the abdomen is very distended. It's pushing up on the lungs and the heart. Those lungs aren't very well inflated, so the baby needed to go on the ventilator. And as well as the abdominal signs, of course, it can cause significant compromise to the whole baby. So this baby needed a lot of cardiorespiratory support. But unfortunately, despite our best efforts, this baby unfortunately passed away the same day, and we were unable to get them to the surgical centre because they were too sick. So that was a sad case. It isn't something we see very often, thankfully, but when it is a severe problem, it is really very, very unfortunate. So prevention, as we've talked about it, prevention is definitely better than cure in the case of NEC. The general feeling is this: we're not 100% sure exactly the speed with which we should feed babies, but the general feeling is that a feeding guideline is always good. So you've got a systematic approach to how you feed babies. As we've said, we like to use breast milk. We'll use donor if we can't encourage mums to use to express, and we invest a lot of time and money in supporting our families to express milk. But sometimes we use donor. We wouldn't use formula really in babies under 30 weeks if we can at all help it. Timing of milk, we're not always very good at getting mum's milk going very quickly. We do like to give colostrum as early as possible to give babies mouth care with that. We like to get babies having a little bit of milk as soon as we can, but that's often the supply issue. And then we talked about briefly with Kath in the conversation in terms of our speed of increasing feeds. There's always been lots of debate. Lots of people have strong opinions, but not a lot of evidence about the speed of feeding. But there was a big study called the SIF study. There's a reference there that was done a few years ago now, and that compared different rates of feeding. I think it was a comparison between increasing milk by 18 mils per kilo per day and 30 mils per kilo per day. And there's been a bit of discussion about the various subgroups, but I think the general impression that certainly I took from it is that it was as safe to increase feeds at 30 mils per kilo per day as it is at 18, and they were just two commonly used incrementing regimes. So 30 was felt to be as safe as 18, and because that meant that babies spent less time on IV fluids and we could get more nutrition into them, we do use PN, but it's not the panacea. We've certainly locally adopted the policy of increasing milk at 30 mils per kilo per day if the baby tolerates it. So that would be our default position. I'll go to the guideline in a second for more detail. Our antibiotic use, we talked about the importance of the microbiome, so we try not to give antibiotics for any longer than we feel we have to. We still probably give too many, but we try and restrict them down. If we've got a bug that we're treating, we try to stop them, even if sometimes we're a bit nervous, because we're trying to promote growth of bugs in the gut that won't be pathogenic, and the more we give antibiotics, the more we'll strip them out. We do give probiotics. There's a variety of forms on the market, but the evidence does suggest it reduces mortality in very preterm babies. So we're trying to, again, improve the growth of lactobacilli and bifidobacter that seem to grow and flourish when you use breast milk. And of course, a bit like the prevention of NEC, we try and prevent our babies getting infected. So we're keen on our hand hygiene, and we try and make sure that we're not moving bugs around the unit by getting to wash and gel our hands between babies. And we could always still be better at that, but it's something we spend a lot of time reinforcing. Antenatal steroids we've touched on. Where possible, we like to go to give those. Deferred cord clamping, I don't think we've talked about, but that's been a big thing in our world in recent years. There's evidence suggests that waiting for a minute before you clamp the cord, keeping baby at the level of the placenta, and not separating the baby from the placenta for a minute after delivery, certainly does seem to improve outcomes in very premature babies. Whether it improves NEC, I think the evidence is a little bit equivocal, but there's a suggestion it might reduce the risk. So we certainly think it's worth doing, and we've spent a lot of time trying to make that our normal practice. And then again, as we've talked about, keeping babies warm, stopping them getting cold, and avoiding things like H2 receptor antagonists and things like that sometimes people use trying to treat reflux, but we don't really think there's any place in the very small babies. So there's our feeding guideline. It's a network guideline that we use across Yorkshire. Babies under 30 weeks are in the kind of red columns. We might start them on 15 mils per kilo per day, but then increment at 30. Slightly bigger babies, we might start at 30 and increment at 30, but anything above 32 and who are well, then we would tend to put them straight onto milk. There is definite, we don't know about exactly the best way to feed 30 to 33 week babies. So under 30, I think we all feel that advancing at around 30 is as good as information we've got at the minute. But between 30 and 33, we've got a study going at the moment called the Feed1 trial that's looking at whether, apart from babies that have extreme evidence of hypoxia in utero, whether it's safe to feed a baby straight away on full milk feeds when they're born between 30 and 33 weeks. And so the arms of that study is milk straight away, whether that's formula or breast milk, or whether we put them on some IV fluids and then increment the milk at around 30 mils per kilo per day. But the results of that aren't out yet, but we're still recruiting for that. So hopefully we'll have that information in the next couple of years. I'm going to hand over to Catherine, who's going to talk to us about a little bit about milk expressing and storage.
Okay, thanks, Sam. So as Sam's discussed, we do massively highlight and encourage our mums with expressing, and at all times we do encourage early expressing. So we've got an infant feeding support team who often go around to see mums and try and get hand expressing going within an hour of delivery, if it's appropriate, if she's stable enough and things. And we can use that for buccal, for mouth care, even if they're not started immediately on feeds. Regarding the expressing and safe storage of breast milk, we can keep our breast milk at room temperature once it's been expressed for 4 hours. If not, we are fortunate enough, we have fridges in each of our nurseries where all of the expressed milk can stay in for up to 48 hours. Once we've removed that milk, we use it within 4 hours and give it to the baby. either used for mouth care or just buccal if they're not actually on feeds, or via the NG tube or a gastric tube as well, building up in increments as we've already discussed. We do also freeze our breast milk if mum gets a good supply going. We can freeze breast milk for up to 6 months. And again, once it's been removed from the freezer, we use it within 24 hours. We put it in the fridge and then we use it within 24 hours. And like I say, we have ongoing support from our feeding support team and nurses looking after the babies to ensure that mums are expressing. We can provide breast pumps when they're here. We provide a little mum's room for them to go and express when visiting. They take home breast pumps. We do offer a lot of support and encouragement with regards to milk expressing. And we can also use donor breast milk as well, which has the same storage guidelines as express breast milk. So we just thought we'd probably discuss a little bit about the nursing care regarding diagnosis. A lot of it's been covered, but on a nursing point of view, and when we're day-to-day caring for these little babies, it's often us that kind of will observe and see that the abdomen's becoming worse over the day throughout your shift. It might become just more distended, become loopy and quite shiny, and also there's umbilical flare and redness around the umbilicus, so we'd always get that looked at, get that examined. If you feel that it's getting worse, we would always report our concerns to the medical staff. Like we've discussed as well, the poor feed intolerance, the baby might show that they're vomiting. We might get bilious aspirates back from their NG tube or a gastric tube. And also there may also be blood present in their stool, all of which are signs that we would be highlighting straight away. And again, from a nursing point of view, because we're kind of the ones that are constantly by the baby's bedside, any change in observations we would be highlighting, but we just thought we'd discuss a couple of those. So unstable temperature, we nurse a lot of our babies are in incubators with up to 85% humidity initially. That's weaned after 7 days. We have a continuous skin temperature probe in place, so any deviations from that, as well as an axilla temperature, can highlight a deteriorating baby. Just general observation changes, so your baby might become tachycardic or tachypneic with a general increased work of breathing. Like Sam discussed on the x-ray, if your abdomen's distended, then it has an impact on your lungs, and that may be the first sign that they show. Hypertensive, tenderness when their abdomen's examined, and general poor colour and poor perfusion. You can see when your baby just doesn't quite look as well as they had done previously. They might have reduced urine output, or just generally dislikes handling, very quiet on handling, not active and not kicking you away when you're trying to do stuff. So on to our investigations. I'll hand back to Sam.
So if we are concerned that a baby might have NEC, we will send some blood tests. We're looking particularly white cell counts. Low white cell counts worry me actually more than high ones often. Low platelets can be a marker of NEC amongst other things. CRP, lactate, glucose may all be deranged. High glucose can be particularly a sign of sepsis in a very premature baby. Talked about X-ray. That's a kind of bit of a classic in terms of a lot of gas in the bowel wall there. You can see the kind of double wall effect there, where you've got gas in the bowel wall leaking out through the inflamed bowel. It's easy when it's like that, it gives you your diagnosis, but many x-rays aren't as clear cut, and it's often a very kind of subjective and debated thing about whether the x-ray is showing signs of NEC. So it certainly isn't a kind of our best test. It again, like we talked before, it sort of adds to the information that you've got, but just because it looks normal doesn't mean the baby's all fine. As I said, the only really way for telling is doing a laparotomy, but we don't have acute surgery here, and obviously putting a baby through that is a significant step. Prior to this, the ground round today, we had been talking a little bit about ultrasound use. I understand that's increasing interest in Uganda. We don't use it much in Bradford. We'd like to do a lot more. It's been difficult to get the kind of training and experience because we don't see huge amounts of NEC. So it's just difficult to get those skills to be able to confidently assess the bowel for signs of it. There's a good paper I found before this that gave quite a lot of markers, so there's a reference there for anybody who hasn't seen it. But You can look for bowel wall thickening or even thinning in extreme cases. Peristalsis, I think, is relatively easy to pick up, or the absence of it. Portal venous gas is probably the only thing I'd be reasonably confident looking for. There's a picture there, and that's really just sticking the probe on the liver and seeing whether you can see the kind of white dots moving through the vasculature that we saw on the X-ray before of gas in the liver. Is a really in the correct clinical context, I think, is a really clear sign that you might be dealing with a case of NEC, and is a relatively simple and straightforward test. Again, getting trained for that's difficult, but sometimes it's just a case of getting the scanner out and having a look and getting comfortable using the machine. So management, we do have a guideline, at least in the south of the region, that we probably use as well, up here in the north. As Kath said, it's variable, I think, a bit in terms of how long we leave babies nil by mouth. We worry about the lack of nutrition they get, even with the PM, because we don't think it's probably as good. If NEC is suspected but not confirmed, and what I mean by that is an X-ray that's a bit equivocal, a baby who's maybe had a bit of a big belly, but it all kind of settles down, and their markers might go off a bit, but it doesn't seem to have turned into anything, and people are a bit dubious about whether it was really NEC. We might only leave them nil by mouth for a couple of days. We might do 5 days up to, but then we'd be looking at maybe thinking about starting a bit of milk and stopping antibiotics at that point. If we've got definite evidence of NEC, again, I think practice varies a bit, but if you've got clear signs on your X-ray, a convincing clinical picture, we might leave the baby 7-10 days nil by mouth or without any milk, if we think it's a pretty definite case of NEC. We'd leave the NG on free drainage. We would usually give some parental nutrition, but I think always give some parental nutrition if we can, to try and support the baby's calorific requirements through that. Our default antibiotics are MOX and gentamicin and metronidazole if we think we're dealing with NEC. We have unfortunately seen the emerging signs of resistance. We're beginning to see gentamicin resistance, unfortunately, which is a worry. And we've got a lot of penicillin resistance, but that seems to cover the majority of enteric organisms that we might encounter, certainly in the majority of patients, but we might change that depending on further results. And then what I'm always looking for particularly is signs of systemic involvement. So if it's confined to the bowel and GI type signs and symptoms, in some ways that's reassuring because it might be limited, but once you start getting kind of more tachycardic, respiratory compromise, as Catherine was talking about, poor perfusion, poor urine output, you're beginning to worry here that you're getting a sort of systemic inflammatory response, and that's very concerning. And I think these babies, we probably don't or aren't aggressive enough with our fluid resuscitation at sometimes. I think you almost have to think about these babies as a septic baby who might present to your A&E department. They're losing a lot of fluid from their intravascular space, their third spacing, they're getting edematous really potentially quite quickly. So I think they do need more aggressive fluid resuscitation than a preterm baby would normally do. And you have to keep very close watch on them and try your very best to try and give them the support they need. It's not always possible to reverse that, unfortunately, though. And then surgery, as I said, we don't send every baby with NEC to Leeds because actually moving them is traumatic and potentially could destabilize them. It's a difficult judgment call to make for us when we will ring the surgeon up with a decision on when to move them, because if we do it too quick, we'd be sending a lot of babies to Leeds who haven't got always lots of beds for babies, and that might be an unnecessary transfer. You might make things worse potentially. So ideally, we tend to keep them here, manage them conservatively with support from the surgical colleagues in the ways that we've talked about. But if they're deteriorating, move them across because they may need further surgical intervention. But if you leave that too long, and sometimes you haven't got very much time, you might miss that window, and that's always a difficult judgment call to make. I think I certainly found that tricky. And then daily nursing management, just when you think you've got a baby with NEC, these are the sort of things that we're doing.
So we always go down the route of kind of minimal handling if these babies might be in quite a lot of pain, just generally quite uncomfortable. So we do a thing, we call it cluster care. So we just do everything all at the same time. So it's kind of just one disruption. So you take all of your obs, you would do all your nappy change, all your mouth care, always all at the same time. So you're not kind of in and out disrupting and disturbing them. Optimum comfort with regular pain relief, IV paracetamol. If the baby's too unwell, then maybe just some positive touch from families that are going to be worried and very scared in these situations. Just trying to optimise the baby's comfort in any way that we can. Close monitoring and recording of OBS. These babies would be on a continuous monitor that would be recording, so it's just watching for those, because like we have discussed, these babies can deteriorate quite quickly. Administer all the appropriate medications, so your antibiotics and your analgesia as well. We would always keep our NG tubes on free drainage and aspirating those frequently, as well as keeping it on free drainage. We'd have a central line, such as a long line put in with PN. Our babies would be nil by mouth, and hugely important to support our families through. It's a really difficult time with often a very sick baby, and not always the happiest of endings. Sam's management.
Yeah, well, really then it's about decision to refeed. As we've talked about, I think that's a difficult decision. It depends a bit on the baby in the clinical context, well, a lot on the baby in the clinical context. We would do it cautiously. Usually, if we think it's unlikely to have been NEC, if we think it was a false alarm, we might, we're confident with that, we might put the baby back straight on the volume they were previously tolerating. But if we're really any suspicious that this was NEC, we would probably start again at a relatively small volume, 20-30 mils per kilo per day, testing out to see whether baby's going to tolerate that, and then increment that, as Kath said, maybe at 20, maybe at 30, depending on how things were going. But you're looking for signs of well, recurrence of the inflammation. You often see that, but it can be possible. Stricture is a real concern. There's a contrast picture there. The inflammation can cause scarring, which then narrows the bowel, and so you've not got an inflammatory process anymore, but you've kind of got a mechanical obstruction, essentially, where the milk you can put in, but you then see baby vomiting a lot, the belly swells up, they might not be systemically unwell, but they just can't pass the milk through, and that can be a sign that baby's developed a stricture, which in our situation would need the surgeons to get involved to essentially come and chop that bit out. But it is tricky. We certainly keep a very close watch on babies when we're refeeding them, and we might be even more cautious in terms of the speed with which we increment. And that's it from our point of view. So thanks very much for your attention.
Fantastic. Thank you, Sam, and thank you, Catherine. And sorry, I didn't introduce you. I didn't know that we were going to have a special guest coming from the back. So
a special guest, a special guest.
Yeah. So thank you for the presentation. And I think Kath said it in the chat, but really fantastic to have nursing input. Especially most of our neonatal units in Uganda are nurse-led the majority of the time. So I really like that, and hopefully we can push that forward in future grand rounds. Any questions from anybody? Maybe I can't see it at the moment. Maybe I'll just ask a question about milk fortifier and where you stand on that at the moment. So maybe some people on the call aren't aware of breast milk fortifier, but there's a powder, a little bit like formula milk, if you like, that can be added into breast milk to make it stronger and give more calories per mil of breast milk. Potentially very useful if it became affordable for settings like Uganda, when we can't access total parental nutrition. But as per now, it's, for those who are on the call in Uganda, it's about 250k per tin, which is a lot of money. So yeah, just interested where you stand on it in the UK at the moment, and what your thoughts would be for us using it here in Uganda.
Yeah, our dietitians are keen that we use it more and more. We've been talking recently about historically we started fortifier once babies are fully fed. I think there's always been a kind of residual concern that messing about with the milk might cause some upset. I don't think, at least I'm not aware of any really good evidence that suggests that using fortifier increases your risk of NEC. So our dietitians, because they're concerned about even with PN and milk, the calorie gap there, are keen for us to use an ad fortifier relatively early on. There's been some issues with the manufacturer that we've been using recently, and we've had one with much higher iron than we'd like. But the one we would normally use has been talked about as starting milk, I think maybe even at 50 or 100 mils per kilo, 120. We did it earlier than that, I think.
Between 100 and
100, yeah. So even starting 45, once babies get to 100, 120 mils per kilo per day of milk. So before they were what we would call fully fed, which for us would be normally kind of 150, 165, maybe 180 for the smaller babies. So yeah, I think we are keen on that, and we would use that. The deferred cord clamping, as somebody's just suggested, I'm not sure how much that's done in Uganda, but that's a simple intervention that we think probably hopefully contributes possibly to reducing the risk of it. So yeah, that's that as well. That answers your question.
Great, thanks. Yeah, Sam, I don't know if anyone else has any other questions for Sam or for Catherine.
One thing about the refit, I was interested about the antiretroviral medication, and when we've had babies who we think, you know, maybe a couple of days before we'd want to refeed them, I guess the question then is, are they going to absorb the medicine? I might be wrong. I can't imagine that medication will trigger NEC. So I guess in my mind, it's about whether the baby will absorb it. So if I thought medication was really important, I might be tempted to start that maybe earlier than a lot of milk, or give it with a tiny amount of milk. But I know I don't know the right answer to that, so other people might do things differently.
Yeah, thanks for bringing that back up, Nelson, and thanks for highlighting your presentation. We kind of skipped over that. We often face that challenge, and I think possibly more often than you do in the UK, because we have a slightly higher prevalence of HIV. I don't think there's good evidence out there. I'd be interested to hear what others do. For us, we stopped the nevirapine until the bilious aspirates have cleared, even if we're still nil pass for the 5 days. Once those bilious aspirates have cleared, we'll reinstate the nevirapine. We just use nevirapine here as post-exposure prophylaxis. I don't know if anyone else has any thoughts on that. No, there's a couple of questions in the
milk,
sorry, go ahead.
I mean, in my mind, pushing the milk, giving babies milk puts the gut under a degree of strain that maybe a medication wouldn't. So I might be more tempted to give a medication than much milk, but yeah, as I said, not sure.
Great, thanks, Sam. Some questions about delayed cord clamping in the chat. Fear over HIV transmission. I think the guidelines are very clear on that. Delayed cord clamping doesn't increase the risk of HIV transmission, and that's quite clear in the WHO guidelines. It is often a fear, Juliet, I agree with that, but I think the way we teach our mothers, or indeed our midwives here, is that, 9 months, although we're talking about preterms here, aren't we? 7 months and 1 minute attached to the cord versus 7 months and 0 minutes. Your risk of transmission doesn't increase substantially in that extra 1 to 3 minutes. So I think that's quite a good way that we've got around teaching that from our side. There's lots of questions about slides. The slides are going to be emailed out to everybody who's attended and registered after the meeting. For recordings, we're still working on that. That's a process. Hopefully in the future it will become something, but bear with us whilst we work that one out. Could monitoring for resolution of the symptoms be appropriate for reinitiating breastfeeding? For example, if the gastric secretions are clear and abdominal distension is resolved. That's from Vicky. Vicky, I think that's a really good question. I mean, maybe Sam, you also want to answer. I think it's weighing up the risks and benefits there, especially on our side. If you were wondering, maybe this is neck, maybe it wasn't neck, and now everything's gone away, I would try a little bit of milk on our side anyway, 30 mils per kilo. And if it truly is neck, it's going to come back. I don't know what you do, Sam.
Well, I think if we were definite it was neck, we would leave the baby nil by mouth and hold our nerve, but we do have the benefit of PN. If we were unsure, we often have this conversation, and we would often maybe just try a little bit of milk after a couple of days, but not go too fast. And I think you just have to balance the risks and benefits, don't you, like we do all the time.
Great, fantastic.
There was a question about milk storage. Just that we do store mum's milk, and we do unfortunately occasionally get them mixed up, which we try very hard not to do. But there was a question about the worry about that. We've not cracked that yet, so we'd appreciate any. But lots of different units have like different boxes. They get some Tupperware boxes and put the milk in and they have a patient number and stickers and even a scanner. But yes, it is something that worries us as well, and sometimes we unfortunately get wrong. But there's various means you can try to minimise the risk of the wrong milk going to the wrong baby.
I think for those of you who aren't in the chat, the question was about can we store breast milk, mother's breast milk in units? And a few people have responded all very similarly, actually. Either there's no fridge, or there's a fridge that doesn't have reliable power, or a fridge that doesn't even switch on. But primarily, I think, as Sam has said, the biggest risk is most of our mothers in Uganda are unaware, or not most, many are unaware of their HIV, hepatitis B and syphilis status, which can all be transmitted by breast milk. So if our mothers, who are mainly the ones doing the feeding and the ones accessing the milk from the fridge, were to pick the wrong milk, it could have bad consequences. But I don't think it means that we can't do it in the future. So yeah, great. Anybody got anything else to add? I don't know what the time is. We've got 6 minutes left. We can finish early. Or Nelson, was there anything else from your side? You brought up some fantastic points in your discussion slide. Is there anything that we haven't brought up in this afternoon?
So, thank you very much, guys. But I think most of the things have been really responded to, and Sam's presentation has been very comprehensive and really quite informative. I think it has really highlighted most of the things and given answers to some concerns that we had. Thank you.
Brilliant. Thanks, then, Nelson.
I just want to say, well, we were just talking before, I mean, there's been lots of comments in the chat about guidelines, and obviously Kathy is working hard on the Ugandan guidelines, but there is quite a lot of evidence for NEC that actually, despite what actually is written in the guideline, just having a guideline on its own to provide consistent management actually makes a massive difference in the terms of prevention for NEC. And it's the same for most conditions, that if everybody consistently on a unit is doing exactly the same thing, it elevates your level of care. And there is a lot of evidence specifically for NEC is that it does reduce your incidence just with a feeding guideline. So that's really a really easy thing to implement to make sure everyone's doing the same thing. Thanks very much to Juliet, to Nelson, Sam and Catherine for fantastic presentations. I think we've learned lots from everybody shared across the world, but also it does show that we actually all face similar challenges, despite whether we have every investigation technology available to us. But actually, it's all about really essential and basic neonatal care, looking after our babies. And hopefully with things like that, we can learn together and decrease the incidence of NEC, which is such a terrible disease. So I just want to say thank you very much to presenters, and thank you very much to everyone who's joined. I think we've had loads of audience participation. It's been fantastic to have questions on the chat. So thanks very much to Kathy for chairing. Thank you very much to our speakers, and thanks to everyone attending. And we look forward to seeing you September the 15th. We'll send some flyers out about the speakers from both the UK and from Uganda. And we look forward to welcoming you then. And I wish everybody a good weekend. Thanks very much.
Thank you.